Hello bachon, welcome to your pharmacology class. Today, we're going to dive into two conditions you will absolutely see in your clinics, rheumatoid arthritis and gout. So pay attention, this is important stuff. Let's get started.
It's a question your patients will ask you, for sure. And why does this happen? Well, today we are focusing on two main culprits. On one side, you have the slow, chronic, grinding war of rheumatoid arthritis, an autoimmune disease. And on the other, you have the sudden, shocking, and incredibly painful ambush of gout. Two very different enemies, which means two very different battle plans. All right, class, here is our game plan for today. We'll start with rheumatoid arthritis, then get into the biologicals, our special forces. After that, we tackle gout. First the attack, then the long-term plan. And we'll finish up with my final pointers for your exams. Ready? Cello!
Okay, first up, rheumatoid arthritis. Now, you have to understand treating RA is not a sprint. It's a marathon. We're not just trying to stop the pain for a day or two. No, we are fighting a long war to stop the disease from destroying the joints. And our main army for this fight? A class of drugs called DMARDs.
So what are these DMARDs? Bacho, the key is in the name itself. Disease modifying. This is so important. These are not just fancy painkillers. They actually try to change the course of the disease, to slow it down. This concept is absolutely crucial for your exam, so please remember it.
So let's meet a couple of our conventional DMARDs, our foot soldiers. You have hydroxychloroquine. Now its big plus is that it has low toxicity, but its efficacy is also kind of low, and it can take 3, even 6 months to start working. And you have to keep an eye out for retinal damage. Then there's leflunomide. This one's a bit more aggressive. It stops the harmful cells from multiplying. It's much more effective, but you have to watch out for liver toxicity.
Right. So what happens when these conventional soldiers are not enough? Well, that's when you call in the special forces. These are the biological agents. They're newer, they're much more powerful, and most importantly, they are incredibly precise. They don't just fight the battle, they go straight for the enemy's leadership.
So to understand how these special forces work, you have to understand the enemy. In RA, the whole problem is caused by these things called cytokines. Think of them as messengers running around shouting, "Attack, attack!" And the one shouting the loudest, the big boss, the general leading this whole inflammatory army, is a cytokine called TNF-alpha.
And this is where the strategy is just brilliant. You see, while our old DMARDs are down on the ground fighting the foot soldiers, these biologicals, they're different. They are snipers. They don't waste time on the small fry. They take aim and go straight for the general, TNF-alpha himself. You take out the general, you stop the attack. Simple as that.
And here are some of our top snipers: etanercept, infliximab, adalimumab. You'll notice they have different delivery methods. Some are injections, one is an infusion. And they work much faster than the old drugs. But, and this is a very, very big but, when you take out a general of your immune system, you weaken your overall defenses. So the biggest risk, the thing you must always watch for, is an increased chance of serious infections, like GB.
Okay, let's switch gears completely. We're moving to a totally different kind of enemy. Gout is not a slow war. Gout is a surprise attack. A patient wakes up in the middle of the night, and one joint, usually the big toe, is red, hot, swollen, and screaming with pain. So our first job isn't about long-term strategy. It's about putting out that fire right now.
Okay, Bacho, look closely at this slide. Commit this picture to memory because this is your entire strategy for gout. You see, it's split into two parts, right? On the left, you have the plan for the acute attack. That's our fire department. And on the right, you have the plan for chronic gout. That's our long-term prevention plan. First, let's talk about fighting the fire.
So, how do we put out this fire? We have two main fire extinguishers. Our first choice, for most people, is an NSAID like naproxen. It's a strong anti-inflammatory and it's tolerated pretty well. Our other choice is a very old drug called colchicine. Now, colchicine works fast. Really fast. But it comes with a price. It can be quite toxic, causing things like diarrhea and cramps. So because of that, it's usually our second choice.
All right, so the fire is out. The patient is feeling much better. Is our job done? No way. If we walk away now, another fire will just start up again next week or next month. Now we have to move to the long-term plan, which is all about cleaning up the mess that's causing these fires.
And what is this mess I'm talking about? It's actually very simple. The root cause of gout is just one thing: too much uric acid in the blood. We call this hyperuricemia. When the levels of uric acid get too high, it can't stay dissolved anymore. It turns into these tiny, sharp, needle-like crystals in the joints, and that is what triggers that horrible, painful fire.
So where does all this uric acid come from? Well, take a look at this diagram. It's basically a production line. Our body is breaking down substances called purines. And do you see that enzyme there in the middle, xanthine oxidase? That is the key. That is the main factory machine that is churning out all of this uric acid.
So, if xanthine oxidase is the factory making the problem substance, what is the most logical thing to do? You guessed it, you shut down the factory. And that is exactly what our #1 drug for chronic gout does. Allopurinol's whole job is to block that xanthine oxidase enzyme and stop the production of uric acid. It's really a very smart and effective solution.
All right, class, let's wrap this up. We've gone through a lot. Now I want to give you the final high-yield points. This is the stuff that you absolutely, positively must know for your exams. So listen up.
First, RA is a long war. You need disease-modifying drugs, not just painkillers. Second, biologicals are fantastic. They're fast, but you must always be watching for infections. Third, gout always has two parts. Put out the fire first, then clean up the mess. And the last point, Bacho, and I cannot stress this enough, this is a classic exam trap. You never start allopurinol when a patient is having an acute gout attack. You have to wait for the fire to be completely out, otherwise you might actually make it worse. Please remember that.
And that's it for today. So I will leave you with this one question to think about. The next time you are in the clinic and a patient comes in with that classic picture, one single joint, red, hot, swollen, and painful, what is going to be your thought process? What's your plan? Always remember, think about the fire and then think about the factory. Well done today, class.